and welcome to our three presenters, Dr. Sharon Millard, Professor Victoria Joffe, and Simon Henderson. We're going to start our first presentation from Dr. Sharon Millard, and she is going to be talking about Palin stammering therapy for school-aged children, 8 to 14 years old, a feasibility trial. Welcome, Sharon, and thank you for being here.
Thank you, Ali. Okay, so as Ali said, what I'm going to talk about today is a feasibility trial into Palin stammering therapy for school-aged children. So this is a therapy program developed at the Michael Palin Centre for children who are aged 8 to 14 years. And it's a trial that was funded by the NIHR. It was sponsored by Whittington Health NHS Trust, and it involved a number of organisations and individuals who brought the whole range of skills and experience that are necessary for a trial into a complex intervention such as this. It's a trial that was started before the pandemic, and then of course with all the problems that we had to close and suspend for a period of time and then reopened after that. So let me give you a little bit of background why we developed this program and embarked on the research in the first place. So there is very little evidence indeed to support intervention for children, school-aged children who stammer. And the sort of quasi-experimental trials that we do have tend to be focused on stammering frequency or stammering severity as the primary outcome. And the problem with that is twofold. Firstly, that frequency is not directly related to impact. So sometimes that doesn't actually make much difference to people, whether they're stammering more or stammering less. And also, therapy that focuses primarily on increasing fluency on its own ignores children's and parents' hopes and expectations for therapy. Children and parents want more than increased fluency or reduced struggle. They want increased participation. They want to feel better. Parents want to worry less. And so therapy needs to be targeted to those expectations. We know that therapists lack confidence in what to do and how to work with this client group, in part probably to do with the lack of evidence. But it means that services are highly variable, and they vary from trust to trust and across the country and even within trusts. And often services are restricted to specialist services either locally or in larger centres such as the Michael Palin Centre, but these are more expensive and they are much less accessible to most people. So this therapy itself, so Palin STSC is a structured therapy package, and it's grown out of the multifactorial Palin model and therapy implemented at the Michael Palin Centre. So it begins with a comprehensive assessment process, which is followed by 10 weeks of therapy, which consist of 1 hour's sessions each, and parents are central to the whole process. The aim, there are a number of aims within Palin STSC: to reduce the impact of the stammering on the child, for the child to be able to speak with greater ease, have more fluency or reduce struggling, to reduce the impact of the stammering on the parents so that they're worrying less about the stammering right now, but also for the child's future, and for the parents to feel more knowledgeable about stammering and how to support their child. So what we want to do is we want to look at the effectiveness of Palin STSC when it's delivered by speech and language therapists who've been trained in the program, and not necessarily just those who are working in a specialist context. We want to see whether this therapy is effective and if it's affected by therapists with different levels of specialism and experience. And the goal would be to conduct a multi-site randomized control trial which would compare Palin STSC to treatment as usual. Now, usually what we see is a therapy compared to a no treatment control group. But in this instance, we have treatment as usual as our control. And the reason for that is that the NIHR, who are the funding body for the majority of the research carried out within the NHS, want to know whether the therapy, the new intervention is going to be more effective than what already exists. Now that leaves us with some problems with treatment as usual when it comes to stammering, because the question is, what is treatment as usual? And Vicky's going to talk a little bit more about that after this. So I'm going to give you a very short summary today of what is all involved in this very complex trial. But if you're interested in more of the detail, we have published the protocol, and so you can get more detail of the design and methods in this journal article, which is open access. So in terms of the feasibility study, now the feasibility study cannot determine which intervention is more effective. It's not set up to do that. Rather, the aim is to investigate the feasibility of implementing a full-scale definitive trial. And so in this case, what we did was we adopted the design that we would seek to use in the full-scale trial. And so it's a randomized control trial comparing Palin STSC with treatment as usual, with randomization at the level of the SLT. So that means when the therapists consented to take part, it was the therapist who was randomly allocated either to STSC or TAU. And those child participants and parent participants that they brought with them to the trial got the therapy that the SLT was delivering. And that there was a stratification by site. So this meant that we had roughly equal numbers of therapists allocated to each of the intervention groups according to the recruitment site. And we did this to try and reduce the influence of the sort of the geographical bias, if you like. So the feasibility study itself had 6 objectives. So the first objective was to look at recruitment and retention rates. We wanted to know if we could recruit speech and language therapists to this trial, if we could recruit children and parents, and if they would stay in the trial. And we wanted to look at the appropriateness of the outcome measures that we had selected and the assessment battery that we put together. And those are the 2 areas that I'm going to report on today. We also did a process evaluation. We wanted to know about the acceptability of Palin STSC therapy itself. Did SLTs like it? Did it make sense? Did the children and parents enjoy it? Did they feel they were getting something from it primarily? And we wanted to look at the acceptability of the research methods. We also looked at treatment fidelity, and we have a poster session on that if you'd like to look into that. And we looked at the health economic measures and the costing for the full trial. So how did we do it? Well, we recruited speech and language therapists, and our target was to recruit 30 speech and language therapists so that we would have approximately 15 in each group. In order to be eligible, the therapists needed to be working with or have the potential to work with children who stammered aged 8 to 14. They needed to be able to attend training for the research trial, and they also needed to be able to attend training for Palin STSC if they were allocated to that group. They also needed to be able to deliver Palin STSC, so the full package of treatment. They needed to be able to take on 2 children who would be part of the trial. And the only exclusion criteria was that they should not be trained in using Palin STSC already. And at this point, this was pretty easy for us to do because it's a new therapy and nobody was trained apart from those at the centre. So the therapists were asked to identify potential participants, and children and parents were eligible if the child had been referred to SLT because of concerns about the stammering, if they were aged between 8-0 and 14-11 at the time of taking consent. Crucially, we wanted the child to make some indication that they would like therapy for their stammer, and they needed to have a parent who would take part in the trial. Children were excluded if they'd received therapy for stammering in the last 6 months, and if they had been at the Michael Palin Centre either for an assessment or for therapy previously. We also excluded any children for whom this trial might cause them additional burden. So if they were taking part in another research trial, or if therapy wasn't indicated because of some home circumstance, or that they were receiving therapy elsewhere for some other condition. that this would mean it would be too much. In terms of data collection, the quantitative data was collected pre-therapy and 6 or 7 months after that point. And the parents and children completed a number of assessments, which I'll show you in 1 second. And we also conducted some semi-structured interviews with children, parents, and SLTs from each group for the process evaluation to find out about the acceptability of the trial and the therapy itself. So here you can see these were the assessments that were completed by the children and the parents. There's quite a big battery of them. I'm not going to go through each of them, but we selected these measures based on our expectation that they would be able to measure change that we would expect from therapy over time, and or because we anticipated that they might predict therapy outcome. And so therefore they would be included as part of the large-scale trial to determine the factors that influence outcome. So what did we find out? Well, in relation to objective 1, which just to remind you was about the recruitment rates for SLTs, children and parents, we recruited as part of the trial post-pandemic. We had 14 trusts who involved, 13 in England, 1 in Wales. We recruited 37 SLTs, which, if you remember, we had intended to recruit 30, which was great. So we were pleased at the recruitment rate. And we indeed had to close recruitment early with some sites and SLTs who were actually unable to participate, which was very exciting. We, again, recruited over-recruited, if you like, for our children and families. We had 67, and again, so that objective was achieved. So this is our diagram, which shows you the recruitment and attrition. So just to, if you look at the green figures there, we had 19 SLTs allocated to PIL and STSC and 18 allocated to TAU. And those therapists, if you go back up to the top of the picture there, they identified 88 children for screening. Of those 88, 67 consented and 56 completed the baseline. Of the 56 who completed the baseline, we had 54 who were still in the trial 6 months later and took part in the follow-up. And that included some of them who didn't need therapy or decided against therapy, but they still stayed part of the trial.
2 more minutes.
Okay, thank you. So in terms of objective 2, we were looking at the practicalities of the outcome measures. So we made a number of changes. These were all put online. We will continue with that. We are going to eliminate any postal questionnaires. The battery will be reduced for the children, but we were able to observe the degree of variability in the group, make the power calculations for the full trial, and decide on the OACs as the primary outcome measure, which measures the impact from the child's perspective. So to conclude, our great and very exciting news is that we were able to recruit and achieve objective 1, and we concluded that the definitive trial is indeed feasible. SLTs and parents were really keen to take part in the research. We have some insights into TAU, which will inform the next trial. We were able to calculate the numbers required for the full trial. So we need 120 SLTs and over 350 children to take part in this trial. And the elements that we introduced as part of the COVID and pandemic, the transfer online of all the procedures, will be retained. So these are the acknowledgements. So thank you to everybody who was involved with this. And I do have some references. If you would like them, you can send me a little email. Thank you very much for listening. And if we've got any questions, I look forward to them later on.
Thank you, Sharon. That was a beautifully done piece of work in the time that was available, and just shows this important work in developing an evidence base for school-aged children. I'm delighted now to welcome Professor Victoria Joffe, Dean of the School of Health and Social Care at the University of Essex, and she is going to be telling us a little bit more about some of this work that she's been involved with. Therapy for school-aged children, what is usual treatment in the NHS? Welcome. Just need to hear you. Vicky, I think we've lost your slides just temporarily, unless that's only me.
Sorry, okay. I was on mute.
That's fine. So we can hear you, and just if you can reshare slides.
I will do. There we are. Bear with me a second. Okay. You should now hear me and see my slides, correct?
Thank you. Yes.
Wonderful. So I'm going to be talking about therapy for school-age children who stammer, focusing on treatment as usual. So why? Why do we want to know about treatment as usual? And what, if anything, do we already know about how children with stammer are intervened or supported in the NHS? So evaluation of our interventions and delivering evidence-based practice is absolutely essential. As everybody knows, it's core to our professional standards. It's very much entrenched and embedded in our HCPC standards of proficiency. To enable us to evaluate research and evidence, we have to have some level of consistency of treatment as usual to allow us to do that. And in fact, it is absolutely an expectation of our funders. So for example, NIHR, when you are putting through submitting a grant, they will very frequently ask you, what's the treatment as usual? What is your control? Because it's the only way you'll really be able to assess effectiveness and efficiency. And I want to really say, even though this talk is about stammering, that's an important point across all of service provision. So that leads us to asking, what do we know about treatment as usual for children who stammer? Well, in fact, very little, or should I say, what we do know suggests great variability. So there was this wonderful and better communication report program, which people will remember around 10 years ago, which reported significant variability in provision for all children with speech, language, and communication needs. And this was much the same in children who stammer. So in a study of 63 children, there was lots of variability with number of contacts, mean number of hours, and considerable variation in approaches. And sadly, more recent research has shown much the same. So if we're unclear about treatment as usual, how can we then evaluate effectiveness and efficacy? How can we improve existing therapy and develop new interventions? What do service users expect from therapy? What do we tell them about intervention if we don't have a clear idea of what people are getting? Really important. How do we ensure equity of care across service users and regions? And how do we apply for funding if we don't know what treatment as usual is? So what did we do? Well, the aim of the study was to collect data from speech and language therapists recruited from the Palin STSC feasibility trial, which you've heard about, and determine what treatment of usual is. We collected nature and type of intervention, dosage and frequency, measures used for diagnosis, assessment, and outcomes, and information about their caseloads. Now, we got data from 50 SLTs at baseline. You'll remember that Sharon mentioned we only saw 37 across the whole of the study, but we were able to include 13 who were involved pre-pandemic. We also had 14 sites in trial, but we're going to report a total of 16 because we had 2 additional ones that were with us pre-pandemic and then had to pull out after. Prior to randomization, SLTs completed a questionnaire to list the assessments that they currently use, information about their caseloads, and summary of the therapy that they typically use with children who stammer in this age bracket. Now, there's an indication. We had sites across England, pretty much representing England, although we certainly could have had more north of Manchester, and we had one site in Wales. So very much would have been great if we had had the time to get more sites in Wales. So what are the findings? Well, firstly, if we look at level of specialism, we wanted to know who considered themselves a specialist in dysfluency, who were seeing the children. And interestingly, we had 46% of therapists who were indeed specialists, but that actually meant that the majority, by a small amount, but nevertheless the majority, who were seeing children were actually non-specialists. And the other question we were interested in asking is, what made you a specialist? So how do you become a specialist? And so, for example, one of the things we asked was who had a postgraduate degree in or training, should I say, in stammering? And we had 44% said that they did, of those who were the specialists. Looking at this referral information for children who stammer, the question was, how many children are typically referred to each SLT each year? And the y-axis is the number of therapists. So if you look, we've got really quite low numbers, around 30 have 8 or less children who are referred to them for stammering per year. But then on the other side, you've got 7 who have 21 or more. So I think the message is this variability, which you will see is keeps coming up across everything we asked. The next question we asked is, how many therapy sessions, not including review sessions, does a child typically receive? And here again, we've got 43 therapists saying that their children receive 8 or less, which again, I think is quite low. And I'm particularly interested in talking about this on the back of the excellent keynote we just heard about dosage and being really informed via evidence of dosage. What about how long a child is typically kept on the caseload? Great variability. We've got 13 therapists reporting that their clients stay on for 19 or more months, so potentially over 2 months. And then you've got, perhaps the majority talking about less, 12 months or less. If we look at the measures used by SLTs, really pleasing to see that we have some, most people are including a case history. Most people are including child interviews, so listening to the children about what they experience, what their views are about their speech. And also great to see that we've got language measures. Much less therapists are having an indication of overt stammering, any sort of measurement of that stammering, any mention of really how we can measure outcomes, which again, I think is quite important considering the emphasis yesterday on outcomes, but also obviously how essential outcome measurement is to measuring effectiveness. Things we actually observed during the study, very good news, we had excellent attendance. So 79% of sessions were attended, indicating how important this type of intervention is to families. Again, 75% of sessions had a parent present. Now, you might think that's really high, but I wonder if we could think about the 25% who didn't, which feels like quite a large percentage when you think about the nature of this work and the importance of generalization. The very nature of when it was, just post the pandemic, not surprising, most of the sessions were remote, but we did have a number who were in the clinic. Big range of session length from 15 to 120 minutes. Interestingly, majority were individual. I probably expected more being group, but that wasn't the case. Group size varied a lot, from 5 to 12. In terms of therapy approaches used, published programs, you'll see lots to do with Michael Palin. Probably not surprising if you think about these were therapists who opted to come on the study and who therefore were already familiar and presumably liked Michael Palin. What is interesting, though, is we've got very few of those programs or approaches where there's evidence for this particular age group. So for the slightly older child, except for the MPC Family Communication Skills Program. And the approaches, probably as expected, they're quite psychological and, as you see, solution focused and behavioral. We asked whether homework was set for the session. And again, we were surprised by this. We were surprised by how little homework was set. So less than 60% for the child and less than 25% for the parents. So that felt quite surprising again, if you're thinking that you want generalization to occur. So in terms of conclusions, I'm going to kind of summarize and wrap up what the findings are and their implications. So as I've said, variability continues to be a strong feature in the provision of treatment as usual in the UK with children who stammer. Referral rates vary widely across the UK. Now, this is a source of potential disparity and inequity in provision, which is a real concern. And we need to really unpick this and explore what is underlying this variability. The role of specialist and generalist in stammering therapy was of interest for us. Less than half of SLTs were specialists in stammering, indicating a level of interest in working with this client group across all SLTs. However, most children who stammer are receiving treatment at the moment in the study from a specialist clinician. But as I've already posed, how do you become a specialist in stammering? Because there really was real variability in what was presented to us with regards to those who were specialists. Pressures and variability evident in provision of intervention with regards to number of sessions available for intervention was very, very evident, again, with regards to the variability. But there felt like from the data that there was a clear need for some children that had this long-term need for continued intervention, or at the very least, to be kept on the caseload. Or that's what the evidence seemed to suggest.
2 more minutes.
Thank you. So some indication that the assessment battery selected by SLTs aligns somewhat with Brundage's recommendations for a comprehensive assessment. A high proportion of SLTs are including a case history from parents, seeking child's perspective of their talking and the impact of stammering, and some language assessment. The majority also are observing the stammering to some degree. However, a much, much smaller subset are taking any sort of measurement, allowing for monitoring of change. And I think this really was quite marked for us. While there is an eclectic mix of approaches used, few have been developed or researched with this client group. And few commonly used assessments were indicated to measure progress or outcomes. So it's unclear how SLTs are making decisions about therapy and evaluating and measuring outcomes. Now, the absence of an overt speech stammering assessment falls short of Brundage's 2022 recommendations, but many argue against this due to stigma, stress, and the ableist approach. We ask about generalization. How does this occur with limited homework and carryover tasks? We want to emphasize this is not a definitive review of NHS services for school-age children who stammer, but does provide the only real insight we have about what's going on in therapy thus far. So it's a snapshot. We feel this type of work is absolutely essential in building a better profile of treatment as usual, and that allows us then to develop and refine better interventions for children and young people who stammer. So again, acknowledgements to the funding and everybody who was involved. And like Sharon, I have a reference list that I'm very happy to provide. Many thanks.
Thank you, Vicky, for a wonderful presentation. And as you say, in light of the dosage keynotes from this morning, that you're bringing up so many interesting questions. So I'm delighted to welcome our third presenter today, Simon Henderson from the Northumbria Healthcare NHS Foundation Trust, also representing the UK's National Stammering Clinical Excellence Network. Simon, if you're able to share your slides, welcome, and we look forward to your talk. Simon is talking about designing hub and spoke learning collaborations for stammering and cluttering, an example of co-production between the UK's national and regional stammering SENs. Over to you, Simon.
Thank you. Thank you.
You might just want to put it on presenter view. That's it.
Let me just see. Are you able to see that now,
Yes.
Ali?
Lovely.
Thank you.
Thank
Thank you very much, Ali, for that introduction, and good morning, everybody. So yes, I'm going to talk to you this morning about a piece of work that we have developed as part of the National Stammering Clinical Excellence Network, where we've developed some co-production work with regional stammering SENs to try to broaden and diversify the learning, the training in the CPD that happens for clinicians working in stammering across the UK. And I'm hoping to really illustrate how that learning dissemination can happen with a worked example from our service here at Northumbria Healthcare. I'll start off just talking a little bit about what we know already in terms of CPD and stammering and cluttering. I'll also sort of think about what the contribution of SENs can be to the field and what we've found through the work that we've developed. I'll briefly think about how SEN learning and the CPD that can be gathered from that can be linked in with the newly developed RCSLT professional development framework. I'll outline the co-production model that we have between national and regional SENs for stammering, and as I said, finish off with a service example of how we brought that learning back to Northumbria Healthcare and what that's meant for us as a service in terms of our workforce, the clinicians in the team, and also our service users. So we know generally that CPD offers really wide benefits for service users and practitioners, and that it can support quality workforce skill mix and outcomes across specialities. And that's something that's really come across in the conference streams so far. Thinking more broadly in terms of sort of wider medical allied health professionals, we know that research has indicated that CPD can really enhance, one's professional sense of self and job satisfaction. And I know that from talking to members of our SEN, that's definitely something which seems to come through from what members can access. And of course, thinking about the RCSLT professional development framework, we know that learning from SENs offers a real sort of transferable element of CPD that practitioners can use to evidence competencies and to really sort of capture their development. But yet, despite all this, we know that CPD can often be difficult to access at the right time and at the right level. And that there is a need to assure quality of learning and applicability, And of course that the landscape post-COVID has really changed things for our CPD with the move now to more online methods. And these are all things that we've been really mindful of in terms of the work that we deliver with National SEN. Just very briefly, in terms of linking with the RCSLT professional development framework, initial feedback from our members and from workforce in the team that I work with at Northumbria Healthcare suggests that much of learning from SENS can really sort of help members to kind of evidence and to capture development in terms of the facilitation of learning indicated in the pink strand in the outer wheel, but also evidence research and innovation. So initial feedback, as I say, is suggesting that these two areas are the main areas where learning and development via SENS can really support evidencing. In terms of thinking about CPD specific to stammering and cluttering, as Sharon sort of pointed out in her presentation as well, what we know is that there is a variable skill and confidence level amongst clinicians working in the field of stammering, and that still feels very alive and well today, that often clinicians are feeling I need to have sort of some element of specialist training in order to sort of work successfully in the field of stammering. And I guess possibly to a large extent that's really motivated and prompted things such as national SLT CPD training programs to develop and to expand. And more recently we're seeing sort of growth and a sort of wealth of development around sort of more specialist CPD programs such as the European Fluency Specialisation. Obviously, much of the training offered generally across the country can be accessed via specialist centres. Common ones are the Michael Palin Centre, CityLit and the Airedale Stammering Centre. We know that online learning in terms of stammering again is really lifting off through webinars from Stammer, or more recently some really good podcasts from the Stuttering Foundation of America. Many services, of course, now we know are sort of doing it for themselves, as it were, and setting up in-house local training and competency frameworks, which is something that we've looked at here at Northumbria and I'll reference later on. And of course, we know that much CPD for stammering and cluttering across the country is originating from what SENS are offering, both national and regional SENS. In terms of the partnership and co-production model of working between national SEN and regional SENS, this was something which we established in 2022, and national SEN are now meeting twice a year with 9 regional stammering SENS across UK hubs. And the aim of this work has been to try to diversify learning and prevent duplication, to try to engage with other key learning and research forums in the field, such as the Oxford Disfluency Conference, to really co-produce together to support what is referenced in the RCSLT professional development framework as this facilitation of learning. So that's been really at the heart of this activity of what we've been doing. How can we cascade this learning on a wider level, to reach wider members? And I guess that as part of this work, as part of these meetings, what we've done effectively is support the development of a national training level sort of needs analysis really around training, and really trying to capture what the current UK workforce learning preferences and needs are in relation to stammering. As part of this, based on member feedback, we've really sort of re-evaluated together with members what it is that National Stammering SEN can offer. And what we've established is that we can offer effective formal learning, which takes the form of 3 virtual study days per year. That learning is always learning that's linked to the evidence base of stammering and cluttering. More recently, we've developed member forums for peer networking and reflective practice, linking in with key forums such as ODC, Oxford Disfluency, the conference. Of course, critically, that co-production with regional SENS to make sure that we can really streamline that learning. And members have access to Signal, which is sort of brought out several times a year with various bits of research and study day information. In contrast, based on membership feedback, regional stammering centres now are tending to offer more informal supervision and case discussion for members, peer networking opportunities, as well as support with regional service and quality initiatives, engagement with local research, shared resource libraries, and of course, dissemination of that key learning from National SEN. I just want to give an example now of a recent learning focus for National Stammering SEN. So based on membership feedback, what we gathered is that there was a really strong interest from members in learning more about the social model of disability and stammering affirming therapies. So in response to that, National SEN had decided that we would set the focus of our learning study days over a period of time, over the past couple of years really, very much around the social model of disability and stammering affirming therapy. For those of you who perhaps aren't so directly familiar with that, effectively when we're thinking about the social model of disability for stammering, it's moving the focus of stammering away from the individual needing to change and instead placing the difficulty part of stammering, if you like, within the awareness and understanding of wider society at large. So effectively, it's looking at stammering as difference, not defect, a different way of talking. As Constantino and colleagues pointed out, it's about working together to promote societal attitude change, acceptance, and allyship. Constantino and et al. Also talk about this movement of stammering pride and really focusing on joyful and spontaneous communication for people who stammer. It's about challenging ableism and stigma as well. And as part of recent study days, what we've done effectively is to look at what the influence of this is on key common approaches that are used, up and down the country in relation to stammering, some of which Victoria and Sharon have referenced in their presentation. So it's for sort of therapy methods such as Palin PCI, parent-child interaction, Lidcombe, Swindon, and acceptance and commitment therapy. And we offered this as part of the study day, an interactive study day, whilst trying to be really aware of the contradictions that we might be offering in the therapy room when thinking about embedding the social model into our therapy discussions, alongside perhaps some of that more traditional impairment-based language. And effectively, it was about moving forward to change the narrative of the therapy that we're offering and really hearing the voice of the client.
2 more minutes.
So just in terms of relaying this learning to Northumbria Healthcare, I was able to relay some learning from the recent study days to our team as part of an intensive therapy group that we offer for children and young people who stammer between the ages of 8 and 15. And effectively, this was me working alongside generalists, newly qualified therapists who were new to working in stammering, and to really try to model and scaffold discussions with them around the social model of disability and stammering. We were able to do this by clinical case-based learning from complex and challenging cases where it was difficult for the child, young person and family to relate to the idea of the social model. And this really allowed us to have open and interesting discussions around the quest for fluency and ableism, and to try to direct the narrative more towards increasing acceptance and reducing struggle. And by part of those discussions with me, that enabled sort of newly qualified therapists new to working in stammering to really think about reconsidering the language of the therapy narrative that they were using, and to harmonise that more with approaches traditionally looking at the speech, social communication and cognitive aspects of stammering. And by virtue of all of this work, it was really trying to question, as an SLT in that forum, are we working as an expert or an ally? And it was more that move towards becoming an ally and really sort of working with what the clients, what the family were wanting and supporting them, being with them and advocating for them. So just some feedback here from some of our service users from that group, and this is the outcomes that they have from being around clinicians who were immersed in the social model and really referencing that in all of the work that they were doing. So here we have a 13-year-old saying, I guess it now, stammering is okay and normal and you can't help it. a 15-year-old saying, I know I'm not the only one who has a stammer and not to worry about it, and you can just let the bad thoughts bounce off you. And to parents saying, I've connected with the idea that stammering is just a different way of talking, and I feel like I'm not alone and neither is my child. There's some really powerful service user outcomes there from the embedding of this learning. Similarly, from our clinicians who had that training indirectly from me as part of the group, really powerful and effective outcomes for them, insofar as them saying things like, the social model actually makes me feel more confident with picking up stammering cases and I enjoy them. I'm better able to discuss things with parents without always having an answer or a solution. And I can consider when to use impairment approaches and how to adjust these to fit in with the social model and the language we use about stammering. So a real shift there in the confidence levels.
Time up, Simon.
We're at time,
I'll
Ali.
just
Thank you.
Move to your last slide and we will finish and have time for questions. Do you want to just show us that last one?
Yeah, so just very briefly, just really to say that national and regional SENDs can offer different forms of valuable CPD, and that really as a SEND we would welcome and advocate for wider rollout of this partnership working between SENDs to other speciality areas. Thank you, Ali, for allowing me.
Thank you. Wow, we have been so privileged to hear 3 such excellent presentations. Now the Q&A has decided to work, so I'm going to take some questions from there and then I'll try and go to the chat to find any that I've missed. We have about 15 minutes, so if you're happy, I'm just going to start with the first one to Sharon. Sharon, how do you think the new neurodiversity affirming movement will impact therapy for stammering due to stammerers being neurodivergent and the community calling to reduce stigma and increase self-acceptance?
Gosh, that's a big question. I think that, it ties very nicely actually into what Simon was talking about, is that there is, what we're trying to encourage is that there is space for everybody and that therapy is not about fixing a condition. Because you have a stammer doesn't mean that you need to do something in order to become fluent. And that's a way in which we've been working, I think, for many years, is about enabling what we want with the therapy, and PLN STSC being one of those therapies, is that children should be able to communicate and participate as they want to and stammer, and that it's part of them, it's part of the richness that they bring, it's part of the richness that we all have, being neurodiverse, and so it's not about eliminating that at all.
Ali, can I say something quickly, because I think it's such a great question, and I kind of mentioned it a tiny little bit as well, and I also think it's about just creating interventions with people who stammer, being really talking to them much more and finding out what their needs are and what they want and what works, because how do we know if we don't stammer? So I think we have to do that much more, and many people are, but I think as a profession we have to do that much more widely.
Yeah, thank you. Okay. The second question is, do you think that remote sessions generate similar outcomes to face-to-face sessions? Again, this is quite a broad question. I'm not sure who would like this one.
I'm going to hand it over to Sharon, but from my perspective, that's an empirical question and we would need the data, and I don't certainly think we have the data. But Sharon, do you want to say anything?
Exactly that. We certainly don't have the data from the STSC trial because we weren't able to look at effectiveness anyway, never mind the factors that were contributing to outcome. It's a clinical impression really, isn't it? And I think that some of us would say, oh yes, the outcomes would be the same because that's what we would like to believe. Others might say, well, maybe they're not. And I think Vicky's exactly right. We need to look at it properly. And I don't know.
Going back to the previous session, preferences, really interesting. Some people love online, some people hate it. I can never get a really clear idea. And certainly Sharon and I, the intention was not to go online. You know, that really shocked us, let me tell you, when we had to change everything.
Yeah, maybe there's a hybrid option in the middle somewhere.
And that's what happened. You know, people went all in the trial. People obviously went all into the remote therapy, and then it sort of started to shift. And I think that, you know, who knows what might have happened. Maybe there would have been a bounce back more into clinic-based intervention. We don't know.
Thank you. The next question is possibly for Vicky. What are your thoughts on using TOMS as an outcome measure for children who stammer?
Yeah, I see absolutely no issue with that, and I'm sure people do. I'm sure absolutely people do. I think that we have to use outcome measures. It absolutely has to happen, and we have to use it across the whole gamut of impairment, and more importantly, people's lives, participation, activity, you know, impact. And TOMS allows us to do it. But the real message for me is people didn't seem like they were doing that. And I just don't know how you can ever start to assess whether your therapy is working or ask those absolutely essential questions if you don't.
Yeah. Okay.
Can I jump in there, Ali, as well? And just to sort of think in terms of outcome measurements, I think, you know, we can look at tools like TOMS. I think there are aspects of that can be challenging alongside things like the social model, as we've talked about. And I think that often it feels really helpful, certainly in the service that I work for, to really try to capture those impact statements from clients, from children and people in their families around where they feel they are at certain points in time, and to really kind of use those impact statements to back up the numbers, as it were, through things like the TOMS. So we've really got that as a reference point, because often that can tell us so much more information, I think, often.
I can't agree more than what you've just said. I think ultimately it's about what people feel. You know, has this improved? Is it improving in the school? Is it improving when they go out to the supermarket? Because if it's not improving in their life, then we do have to ask the question, why are we doing what we're doing?
Yeah. Thank you. Okay, now the next question might come to you, Simon. What would you suggest in terms of assessment if you work in a private setting with no previous stammering cases and therefore no access to specific assessments?
Okay, I'm assuming perhaps that means assessment with a child and family. Is that
I think
right?
it possibly does. It's anonymous, so I'm not sure, but...
Yeah. Well, I think often, you know, what we're looking at is kind of meeting with the child, young person and family, trying to take some form of sort of history of where things are at the minute and where things are, trying to get a really clear overview from the child, young person around what they're thinking, feeling about their stammering, about their talking, and really trying to work out from them, you know, what it is that they want to get out from their time accessing a speech and language therapy service. I think depending on the case, it's looking at sort of other wider language, speech assessments to go alongside sort of things concerning the stammering. I think sometimes as part of the assessment process, it's really important for children and young people to try and gauge a perspective from school partners, from education, around where they feel things are and where the challenges are, because that can really map on to what we think might be helpful for us to offer, you know, as a service. I think from the things that I was talking about in my presentation, I think it's really important from that early outset of assessment to be really starting to talk about that idea of the social model of disability and what that means in terms of stammering, so that we have a really realistic expectation from the outcome, from the start around what the outcome of therapy might be, you know, rather than as Sharon was saying, then moving away from this idea of fixing the stammering to being with and supporting. I hope that answers parts of that question. I'm very happy with the person to have further discussion by email or whatever if that hasn't.
Could I
Sharon?
say a little bit more about that? So, you know, one of the things that is important for us to do as well is to use some standardized measures that are available to us. So as part of evidence-based practice, what we should be doing is, you know, if we are using a therapy approach, we should be evaluating what we're doing for the individual as they move through therapy over time, so that we can make changes. But we should also be looking at our outcomes in relation to the published data, to be saying, okay, is this therapy as effective as I would expect it to be in my clinic? And if it's not, why might that be? What is it that's different? What do I need to do differently? Why? And I think in relation to standardized measures, I think that those are very important as part of that. When we're looking at more data, and something like the Palin Parent Rating Scales is free to use, so you can register to use that. There is the satisfaction with communication in everyday situations, which is just a very quick scale, that again, free to use. There are measures which are available which help with the clinical informing about therapy and the content of therapy, but also evaluating over change over time. So again, if some of those on the Australian Stuttering Research Centre, which are free of charge, and the OASIS is worth the investment for the impact on the child.
Thank you, Sharon. Now, while we've got you, a quick question for you, Sharon. Is the Palin STSC training running?
I am afraid that the Palin STSC training is currently only available for people who are involved in the study. We will be applying for a full-scale trial. And the reason for that is because we haven't established whether it's effective or whether it's more effective than what already exists. And so I think we have a responsibility to our families to establish that first.
Thank you.
But watch the space, because we will be applying for money for a full trial.
I think we can get one more question in. This is quite a long one, but I'm not sure which of you wants to take it. Slough is lacking in SLTs, and we have a 2-year waiting list for the children to be seen. What can teachers and teaching assistants do to support children with a stammer while waiting for assessments? It's clear that it affects children's confidence, and as they get older, they stop putting their hand up and talking in general, which is heartbreaking. And there's a worry of them being made fun of in the future in secondary school.
Gosh.
Well, I'm going to hand over to my colleagues who work with.
And I think sadly, sorry, and I'm sure Simon has something to say about this too. I think sadly that what Vicky is talking about, that's not unusual. And I think that one of the things is to create that environment where communication is what is valued, not whether it's stammered or whether it's fluent. And I think that there are centres, there's like the Michael Palin Centre, who's very happy with, there's a helpline where teachers can ring in and get advice. There's a referral route for children to be referred to get assessment advice and sometimes therapy. And I think maybe, if there's therapist involvement in the SENS, even if they don't have a service, they can at least provide advice. Simon, have you got stuff to add to that?
Yeah, I mean, I think that, the issue around sort of teacher confidence levels around stammering, what to do, how to respond, it can be very variable, can't it? And I think it is a real difficulty. I think it's where initiatives such as the Stammering Information Programme can be very helpful. For schools and staff to try to access the Wait I'm Not Finished DVD. And I know that there are related resources that go alongside that, such as a pupil planning sheet to work out what an individual child's preferences might be in certain speaking situations. I think the other thing from my end would be really trying as far as possible to facilitate that openness between sort of teacher and child, to try and get the child's perspective around what they would really want, how they really want their teacher or their friends or people around them to react to the stammering in terms of openness about it. But it's a really tricky area. It's an area where I think we need to have kind of more development and more consistency. But I think my go-to in that particular situation would be to try to tap into the Stammering Information Programme resources. And again, I'm sure that we can signpost this delegate to that in some way, if that would be helpful.
Yes, those resources are on the Michael Palin Centre website on the teachers page. So the video is there and all the suggestion sheets are freely downloadable.
Can I quickly say, because Sharon said it, and I think it's such a great message for this whole session, is, you know, celebrate the communication, celebrate what's been said, not how it's been said. And if we could all of us do that more, I think we'd all be a lot happier. I'm sure the service and the person who wrote in has already thought about this, but as soon as you read it, I thought this is a service very close to the University of Reading. And I just wonder whether contacting the University of Reading, who has a whole host of speech and language therapy students, placements are dire. We're always looking, and that just might be another suggestion. But I'm sure they've thought about it. But anyway, if they haven't, they should.
Wow, that has been such a wonderful session with the three of you. Thank you so much. On my clock, I think our time is up at 11:40. So thank you for answering so many of the questions and for your really in-depth and inspiring presentations this morning, and wishing everybody a really lovely day for the rest of the conference.
Bye-bye. Thank you.
Thank you, everybody.
Thanks.